Major funding for these broadcasts has been provided by grants from New York Community Bank, AmTrust Title Insurance Company, Perfect Building Maintenance, M&T Bank, Customers Bank, Marks Paneth LLP, Capital One Bank, Collins Building Services, Meridian Capital Group. Additional support has been provided by grants from AKA Hotel Residences Corman Communities, Ariel Property Advisors, Amerant Bank, Bank of America Merrill Lynch, Briarwood Organization, Chase Commercial Mortgage Lending, Chase Commercial Term Lending, Citizens Bank, Dime Community Bank, Douglaston Development Levine Builders, Flushing Bank, Friedman LLP, Handro Properties LLC, Handler Real Estate Organization, Hodges Ward Elliott INC, Investors Bank, James D. Kuhn Real Estate Institute at Syracuse University, John Casamatides Red Apple Group, Keysight Capital Partners, Matone Group, New Banks, Newmark Knight Frank, Ocean First Bank, Optimum Window Manufacturing Corp., People's United Bank, Rockefeller Group, Rosewood Realty Services, Stonehenge NYC, SVN CPEX Real Estate Services, Tierra CRG, the Meringer Family Foundation, and these friends. We have an epidemic. It's called Alzheimer's disease. It's growing by leaps and bounds. People don't understand it. They hear it, they hear dementia, they hear Alzheimer's. They don't know what's going on about it. And I myself are not that knowledgeable on it. So today I've assembled a group of individuals to talk about the disease, to talk about the drug treatment programs, and also to talk about how to live as the caregiver on the disease. My guests include Dr. Howard Phillip, who is the founding executive director and chief science officer for the Alzheimer's Drug Discovery Foundation. Pamela Newman, who is a PhD, Dr. Pamela Newman, who is a caregiver of her late husband. And my good friend Mark Altheim, who is a caregiver to his mother. So tell us what are the facts and the statistics on Alzheimer's and what your foundation does?
Sure, thanks. Well, the facts are that Alzheimer's is the leading cause of disability in people over the age of 65. It's the fifth leading cause of death. It's the only disease for which there are no treatments, no effective treatments to slow it down. It's the only disease, chronic disease of old age, where the number of people getting the disease is increasing, while the number of people with cancer and heart disease who are dying from those diseases is decreasing. It's estimated that if we don't find effective treatments for this disease in the next 10 years, the cost of caring for Alzheimer's will approach $1 trillion and could bankrupt Medicare. It's the most expensive disease in the United States and all developed countries around the world. It's more expensive than diabetes, hypertension, because of the cost of medical care and caregiving.
Now, what's the mission of the foundation that you created with the number?
So Ronald and Leonard Lauder founded this. I was the founding executive director, and we had a very clear mission at the outset, this was 21 years ago, to do one thing, and only one thing. And that was to accelerate the development of new drugs. At the time, I did a survey of the biotech industry in the United States, and there were 1,600 biotech companies, and only 3 had any kind of program in Alzheimer's. It was very early days. We also, when we had our incorporation papers, the mission was stated to also develop biomarkers because they're so essential.
Explain for the consumer, for the general public, what a biomarker is.
Cholesterol is a biomarker for heart disease. Cholesterol was discovered as a risk factor for heart disease in the 1950s. Today, pharmaceutical companies can develop drugs for heart disease if they lower cholesterol. So cholesterol is a biomarker or an indicator that somebody has heart disease, and then if you treat the cholesterol number itself as a biomarker, that you might have an effective drug to prevent heart attacks, and that's how the statins get approved. We have one biomarker right now that's been approved by the FDA for Alzheimer's disease, and that's a PET scan. And it's really a remarkable, revolutionary technology because the only way we used to be able to detect Alzheimer's and be sure about the diagnosis was with brain biopsies. But today, a patient can go to the radiology office and get a PET scan, and the plaques and tangles that are so characteristic of this disease at autopsy can be seen. The plaques and the tangles, by the way, can be seen
Now,
with PET scans.
when we were getting together in the green room before, you said that you could do a genetic test also.
Yeah. So the genetic test is a risk factor for Alzheimer's. 20% of people in the community have a gene called ApoE4. And those people, if they have two fours, one from mom, one from dad, their risk of getting Alzheimer's disease is 15 times the general community. And 60% of people with Alzheimer's disease have an ApoE4 gene. So it's really a risk factor. The thing is, what's the point of testing it, knowing about this? Well, one thing is it's going to lead us to new drugs. And we've been trying to drug, as we say, the ApoE4 gene to make it better. And right now we're doing gene therapy at Weill Cornell, and we're going to fix ApoE4 by giving ApoE2, which is a protective form of apolipoprotein E, to people in a virus that will change the whole thing.
Tell me about your late husband and how you found out that he had Alzheimer's and so on.
I was dealing with a perfectly healthy, vibrant, active man, an outstanding squash player, athlete, tennis player. We were going to take a vacation, and something told me that something wasn't right. We were having fish for dinner at a restaurant, and I said to him, why don't we go check this out, because we won't be near our usual healthcare capabilities. And my husband would normally say something like, are you kidding? Why would we do that at all? And he said, no, that's a good idea. That night, we went to the hospital, and it appeared he was having a subdural hematoma issue, and we had surgery. He got better from that, and time went by, and we had a second surgery for a second subdural hematoma, and he got well from that. And then he still didn't seem well. I mentioned it to a friend of mine who suggested I go see Dr. Fillett with my husband, and Dr. Fillett identified what the issue was.
Now, you didn't do a PET scan at that time as
It was a clinical diagnosis.
A clinical diagnosis.
Yes. It was before they were really widely available.
Let's talk about your mom.
Okay, so my mom, I think the tipping point was when she was driving and couldn't find her way home. Mm-hmm. And she just did not know how to drive home. And then that cascaded into us having to take her car away. And then we were, through the Albert Einstein College of Medicine, there's something called the Brain Center up at Montefiore Hospital, and she had a test done, a clinical test, and she didn't know who the President of the United States was. She was forgetting certain other things that spoke to the fact that this was Alzheimer's that caused her dementia. Personally, I have my own theory. She was on Valium for many, many years, self-medicating for 30, 40 years. Mm-hmm. And I don't really know the causes of Alzheimer's. We don't know what they really all are. I certainly defer to the doctor on that. But I think that she was on some serious medication for a long, cumulative time. And so now she's wrestling with the disease. She's functioning.
She's had it for, like you said, 4 years.
She's 79, and she has had it for 4 years, yeah. She'll be 79. So she's had it for about 4 years, but possibly earlier, I don't know when the clock
Pamela,
started.
your husband?
Passed away when he was 78.
So he had it for 4 years, you
Well,
said?
4 years that we were dealing with it in what I would call a more severe stage. Mm-hmm.
Do you think maybe the hematomas that came up had a possible cause for increasing the likelihood of the Alzheimer's and the dementia?
Yeah, absolutely. absolutely. Subdurals. Well, there's a couple of things. People that have those kind of bleeds in their head tend to have amyloid actually in their blood vessels, and it makes the blood vessels in your brain fragile, and so you can have bleeding in your brain from that. But there's no doubt that this kind of traumatic brain injury is a risk factor for making it worse. But it doesn't mean that the underlying process is any different, because we know now that the underlying process of Alzheimer's takes 30, 40 years before, at least 20 years before someone actually starts having symptoms.
So why are we having this epidemic? Why are the numbers increasing so much radically over the years?
Well, it was
today?
always there. It used to be called senility, and we used to think that senility was a normal part of aging. Alzheimer described Alzheimer's disease in a 52-year-old woman who was pre-senile.
Right, he did in 1907.
In 1906, 1907. But nothing was done about translating that into what senility might be until 1970, which was actually the year I started medical school, when some doctors in London did a very simple experiment. They looked at the brains of older people who died who were senile, and they stained their brains with the same dye that Alzheimer used in 1906, and lo and behold, people who were senile had Alzheimer's disease. So that was the day in human history that senility went from being thought of as a normal part of aging to being recognized as a disease of old age.
Now, what's the difference between Alzheimer's and dementia?
So dementia is a word that we use to describe a patient. It's like saying if you came into my office and you were pale and you were feeling weak and you were tired, and I did a blood test and found out you had a low blood count, I would say you had anemia. Right? And the next thing I do is, gee, why do you have anemia? Do you have sickle cell disease? Do you have a blood loss from a cancer in your gut? You know, we try to figure out the cause. So dementia is a word that describes the patient. We have certain criteria. Usually 90% of the time people have memory problems, plus they have disorders of language and executive function like reasoning and emotional control. So it's deficits in cognition in multiple domains of what the human mind normally does. And it's severe enough to cause functional impairment, like an inability to drive, inability to do the normal work that somebody does. If it's a housekeeper, inability to do housekeeping. It's just a decline in function.
Your son, you have siblings. How are they, as caregivers, handling mom?
Well, my dad is the primary caregiver and has done a phenomenal job in trying to care for my mother. It's extremely sad for him. It was also very difficult to accept that she had it. And he, along with me, my brother, my sister, my wife, and my brother-in-law, it's a team approach. Really a lot of love. It's really the best recipe, a lot of hugs, a lot of trying to find out what medications may work, what kind of art therapy might work, and really taking care of the caregiver,
You know,
my dad.
which is interesting. How do you when you're taking care of your late husband, what type of work does the caregiver do? You know, we hear the term, but we don't understand what is the role, or what do you think is the main function of the caregiver? Pamela?
I think the hardest thing for me was having the ability to let go of what I expected my husband to be able to do and what he in fact could do. That's a retraining of the individual, in this case the wife, so that I had to reprogram myself in hundreds of ways, including recognizing what a friend of mine said to me once, that this is an opportunity for comorbidity. And I think with a spouse, you have that impact when somebody you love very much is gradually leaving you on every front, mentally and physically. So the individual has to readjust. I liken it to a war. You're in battle every single day.
Mark?
Yeah, I think that just helping the person put on their clothes, put on their makeup. My mother gets confused that lipstick is eyeshadow. And my father went from being taken care of by my mother for all these years, and sometimes it's more difficult when the caregiver is the husband, not to be sexist, but traditionally the wife is taking care of the husband. So you have a situation where the husband used to be taken care of by the wife, now has to take care of the wife. So it's every task from helping, budgeting, food shopping, driving, helping them get from point A to point B. It is a really difficult situation, and thankfully we had long-term care insurance. So you have a chunk of money that you could pay people. And now we really need 24/7 help because my father could no longer handle the psychotic episodes that my mother has that are impossible for anyone to predict and very difficult to rationalize and reason with the person who's going through those psychotic episodes.
Which relates, how do you get quality help to take care of this?
Yeah.
I mean, I don't believe there's training like in medical school to learn certain things. In nurses' aides, how do they become qualified to take care of an Alzheimer's patient?
Well, first of all, I'm a geriatrician, so this is my specialty, taking care of older people. I've been taking care of older people and their loved ones with Alzheimer's for 40 years. And part of what we're talking about here is that part of the role of the doctor should be to make an assessment of what the care needs are. Like you heard, billing, is it managing finances? Is it as basic as helping somebody just get dressed? So we do what's called a functional assessment, and we do it in a structured way to ask questions to determine the needs of the patient because of the functional deficits. And then from that, we can determine what kind of home care a person needs. Do they just need a companion to give some respite to the caregiver 2 hours a day? Or do they need a home health aide to just aid in the basic activities of daily living, like bathing and continence and dressing, housekeeping and shopping? Or do they have nursing needs if they're in the more severe stages? So that we can do a functional assessment, determine what the care needs are, and then refer someone to a social worker. Most doctors don't know the phone number of a social worker, but it has to be a team approach. It can be a geriatric care manager, it can be a social worker, it can be a home health agency. There's any number of these in New York City. And getting quality of care, as you said, getting quality care is really important and really hard.
Dr. Phillip brings up the social worker. Did you have a social worker?
I definitely did. I also think that this disease frustrates the best caretaker. I think that I lost my husband 7, 8, 9 times, and I was very, very careful and aware of the likelihood that he could disappear on a moment's notice. It seemed impossible, but he would just take off in seconds. He would be standing next to me, and then he wasn't. So I think that it's a very hard assignment for anybody professionally or related to the individual.
What about you and your family with the social worker
So we
or a
have a
psychiatrist?
battery of people. My father actually has a coach, a geriatric coach, I would call her, that helps guide him on how to caregive for my mother. And there is my brother, thankfully, is a psychologist, PhD, so he has tremendous resources and ability to help manage the situation. We're very fortunate. I mean,
Yeah, this is very unusual.
Very unusual.
Most
3
people.
people.
So here's the next question. It's father, son, husband. How do the grandkids and the siblings take this?
It's a big tax on those next generation, especially if they're in their 20s and they've known these people for their whole life. It's difficult to watch for them, and I think that I think the burden with the grandchildren with any caregiving tasks is quite enormous. Again, I would go back to love and hugging.
Yes.
And calls, and with my mother especially, and with my father. So there's caregiving for the caregiver, and there's caregiving for the patient. And a lot of times the patient, in my mind, gets lost because the caregiver is so burnt out from doing it that you forget about the person who actually has the condition. And it's my mother who has the condition. And thankfully, she's getting weaned off of a lot of medications, especially the Ativans and the Valiums. She's on Seroquel for her psychotic episodes, but a pretty low dosage. And her doctor, Dr. Malik, is a real advocate for lowering the amount of medications that she's on at this point in time.
Let's talk about the recent drugs and the programs that you've done, because I've gone to your website and you're talking about some products and research you're doing.
So there's over 100 drugs in development now for Alzheimer's disease, which is amazing because years ago there were none. Our foundation has its fingerprint on about 20% of those drugs. The first series of drugs over the last 20 years that were developed were to try to remove the amyloid from the brain, with the theory that if you remove the amyloid from the brain, people would get better or the disease would slow down. And all the trials failed. But what happened was we didn't know, because we didn't have a biomarker to see which people really had amyloid in their brain in the trials. And it turned out that when Lilly did one of the trials, they actually used the brain scan that we developed to see if the people in the trial had the amyloid in the brain and if they had Alzheimer's disease. And 35% of the people in the trial that were enrolled by dementia experts around the world, 35% of the people in the trial didn't have amyloid in their brain, and the target of the drug was to remove the amyloid. So that was a game changer in our field. And then Biogen comes along, and for the first time in the last 25 years, Biogen does a study where to get into the trial, you had to have a positive brain scan. You had to have amyloid, which was the target of the drug, in your brain.
How many people are involved with the study normally? How many patients?
So this was a phase 3 trial. Actually, they did 2. One phase 3 trial in Alzheimer's cost about $300 to $400 million. They had to do 2 of them to get towards FDA drug approval. So you're talking about somewhere on the order of about 3,500 people around the world. These are enormous undertakings, and they have to be so carefully done because they're under regulatory science. But what the Biogen study showed, which was really interesting, this was a very successful trial, because what they showed is that the people who had a positive brain scan at entry, who got the drug, after 18 months, about 80% of the people had no amyloid left in their brain, which was the purpose of the drug.
So if they don't have the amyloid in the brain, what happens to their mental condition?
Exactly. So this is the first rigorous test that we've had of what we call the amyloid hypothesis, the amyloid theory. And what happened was that there was tantalizing data that looked like if you remove the amyloid, that people actually, the disease slowed down. And there's been some ups and downs with the analysis of the data, but where we are right now is we have one positive trial, we have one negative trial, but we have good data that it looks like the people that were on the highest dose of this vaccine that's given intravenously actually had a slowing of their rate of decline in cognitive and functional impairment over time. So it's looking like for the first time we have a clue that if you remove the amyloid from the brain, that we might slow it down.
So that's a slowing.
Slowing.
Okay. What other drugs are being used?
So 75% of the drugs that are currently in development now are not related to the amyloid. They're related to other things. Our foundation has taken the strategy that aging is the leading risk factor for Alzheimer's. And we know so much about the biology of aging from 100 years of research. So inflammation, for example, is a hallmark of aging. And there's inflammation in Alzheimer's disease in the brain. And we know that even systemic inflammation from things like arthritis can affect your mind. If you get an infection, how do you feel? You feel sick. You feel tired. That's called sickness behavior. That's the effect of systemic inflammation on your brain. And when that happens, it triggers inflammation in your brain, and that kills brain cells. So the largest part of our drug portfolio in development right now are anti-inflammatory drugs to reduce the amount of inflammation in the brain.
Now, how many of them have been approved for FDA
None have been
approval?
approved, but they're in phase 2 of clinical development. Now, the FDA, there's 3 stages of clinical trials. Phase 1, where we measure safety. Phase 2, where we look at more safety and efficacy for the first time, whether the drugs are effective. And then phase 3, where we have proof of a concept and proof that the drug really works. That's the stage before.
So here's the question today. If there's a family history, what do you recommend?
We have a website called Cognitive Vitality, all one word, cognitivevitality.org, that describes all this information. It does I have 3 PhD scientists on staff who are evaluating all these prevention interventions like exercise. So exercise is a really interesting intervention. And by the way, let me just give the big picture here, the soundbite. Alzheimer's disease can be prevented. We know that now. We used to say that everything, the soundbite was everything that's good for your heart is good for your brain. But now we actually know that from clinical trials, of randomized trials of very large populations. We know that exercise helps in preventing it. We know that Mediterranean diet is good for a healthy brain. We know about not smoking is a good thing for your brain, not drinking too much alcohol. If you have diabetes, hypertension, or other heart conditions, that those are going to affect your brain. You want to take good care of those. Sleep is a really important measure. Sleep, if you're not sleeping, avoiding stress. All these things that are lifestyle factors and disease-modifying factors like diabetes and hypertension. If you manage those well, the studies show that you can delay the onset of Alzheimer's disease. Exercise is really interesting. I was talking with an exercise physiologist. We were trying to figure out, how does exercise protect your brain? So we did a very simple study. We did MRIs on a group of 50, 75-year-olds. And we looked at their brain volumes, because the normal brain shrinks about 0.4% per year with aging. And then we looked at their memory testing and their neuropsych testing. And then one group went into a fitness center 3 times a week for an hour and a half, and they stretched and they exercised and they socialized and they went home. They went for a brisk walk. Part of that was a 45-minute brisk walk 3 times a week. And the other group came into the center. All they did was stretch and socialize. And we measured the brain volumes. And the people who took that 45-minute walk 3 times a week, their brain volumes, their hippocampus, which is where Alzheimer's disease starts in the brain, actually got bigger. Didn't decline with aging over a period of 6 months. It actually got bigger. And their memory and their other neuropsych function improved, while the people who didn't just take that simple 45-minute walk, their brain volumes declined according to what we think of as normal aging, and their memory got worse. And then we wanted to know what the relationship was, and it turns out that the muscles release a factor called BDNF, which is the most powerful, what we call neuroprotective factor for the brain. And so now we're trying to develop drugs that mimic BDNF.
So here's the hope. With the research that your foundation is doing, with the work that Caregivers are doing, people to learn more, and with the knowledge and the venue of my show and other things, I hope that people learn more about it. I'd like to thank Dr. Howard Phillip, Pamela Newman, and Mark Altheim, and I'll see you next week.